Our next speaker is Susan Dentzer, who will be talking about what disrupting innovations could change the delivery of cancer care and spur progress in better support of the care force. Ms. Dentzer is a visiting fellow at the Duke Margolis Center for Health Policy of Duke University that focuses on health system transformations, biopharmaceutical policy, and other key policy issues. From 2016 to January 2019, she was President and Chief Executive Officer of the Network for Excellence in Health Innovation, a nonprofit, nonpartisan organization composed of more than 80 stakeholder organizations from across all key sectors of health and healthcare. She's held a number of additional positions that are frankly too numerous to comment on. So, Ms. Dentzer.
Thank you, and good morning, everybody. As with many people in this room, this issue of cancer and cancer care and the cancer care workforce is both of great professional interest to me and also personal interest to me. I lost a sister to lung cancer, and my son suffered from leukemia. Thankfully, he's doing well. So like all of us, I see these things through the lens of both a family member of people who've suffered from cancer as well as a policy expert who's trying to think through how we can do things better in the future. Let me just give you a quick sense of what I'm going to talk about. The role I agreed to take on today was to try to envision the future 5, 10, 15 years out of the cancer care workforce. So I want to build on a lot of what's been said the last couple of days, both what we see, obviously, with rising cancer prevalence, what we see in terms of the trends of technology, the workforce, et cetera, and pull that together into some thoughts about where we might go in the future. The technology piece, obviously, is preeminent in a lot of my thinking, and you'll see that, but I always emphasize that we can't get overly obsessed about the technology. We have to think about the goal is putting the technology and people together in new and different ways, largely. And of course, obviously, availing themselves of the latest in the science as well. So I'm going to talk about that. I'm going to talk about addressing some of the barriers to getting to where I think we could go, because I think the barriers are profound and really need a very important, to be a very important part of this discussion. And then, of course, I hope to conclude with some implications for the workforce. I'm going to draw a lot on a report that we did in my former position at Knee-High. This was a report that we called Healthcare Without Walls. We published this in October on Amazon. And it tried to really pull together a lot of what we were thinking about the future of healthcare generally. And I very much take the point, as we heard earlier, that cancer is a unique aspect of healthcare. But I also think there are some pieces of what we came up with that apply very much to the cancer sphere. As we tried to envision what the future of healthcare could look like, we found it very useful to develop scenarios of patients, or as we prefer to call them, people, in the future who might have particular conditions of various sorts and how they could be addressed with the combination of new technologies and new aspects of the healthcare workforce. So one of the scenarios that we came up with was a fictional one, and completely we made all of this up. We came up with a fictional scenario of a person we'll call Dave. And our vision of Dave was that he is a very well-educated natural scientist living on Kodiak Island, Alaska, where he's very healthy, he's outdoorsy, et cetera. As you can see here, loves to fish on the weekends. He develops a hacking cough that won't go away. And after dealing with that for some months and being, of course, the typical man, he doesn't get himself to the clinician right away to be seen. But after being nagged finally to do that by friends, he ends up at the critical access hospital on Kodiak Island, one of the few places where you can go to get health care. And there are primary care physicians there and also a few specialists, so he feels as if he's in good hands. He gets worked up there. The clinicians are concerned. They do a chest x-ray. They do some additional imaging. And they discover a mass, and they say, Dave, we're going to biopsy this, but it doesn't look good, and we think it might be lung cancer. So Dave, being a PhD scientist, what does he do? He goes home and he gets on the internet. And he reads everything he can possibly read about lung cancer and decides that given his profile as a healthy young man, non-smoker, it's probably non-small cell lung cancer. So he starts to read as much as he can about that. And the more he reads, he realizes that there are some certain things that he needs to do. And he starts to think about how he can approach his treatment, assuming that it is, in fact, non-small cell lung cancer. So he decides that he really needs to get to a very expert facility to be cared for this. He thinks he has to have direct connections, obviously, as soon as possible with the clinicians there to discuss possible treatment options. He starts to think about where these are in relation to Kodiak Island, Alaska. The answer is far. So what does he think he needs to do? He needs to get on a plane and fly 3,000 miles to get to the major cancer center. It happens to be in a high-cost city. He thinks he's probably going to have to get a $400 a night hotel room to stay there. He's going to get examined. He's perhaps they will avail themselves of some sophisticated AI-enabled information systems to decide on the protocol. Then they'll decide on the protocol, and then what? What does he do? Does he move there for the course of his treatment? He's not sure that that's going to actually be covered by his insurance. Does he empty out his 401k for this treatment, et cetera, et cetera, et cetera? Well, as he contemplates all of this, he thinks, I think there's a better way. I think that this is what I could do. I've read that my tumor should be genetically sequenced in this day and age, and I think that that should happen, and those results and my images should be able to be sent to Dr. Fred at the Major Cancer Center. I should be able to have a telehealth consultation with him once he's got all of my information. He should then be able to avail himself of the AI-enabled system to review treatment and so on and come up with a recommendation for me. He will possibly decide that I would benefit from a targeted therapeutic agent of some sort, which should be able to be prescribed and dispensed from a specialty pharmacy in Seattle and sent to Kodiak Island by drone, where it could be administered to me. Now, this is what Dave thinks, and this is how Dave thinks the system should work. Let me ask you, what of this could happen, technically speaking, today? Telehealth, obviously, he could have the sequence set, the images sent, et cetera. Obviously, Dr. Fred could consult the AI-enabled system. Obviously, the targeted therapeutic agent could be prescribed out of the Seattle pharmacy. The only piece that couldn't happen today is the delivery by drone, because there isn't currently drone service to Kodiak Island. So for now, we have FedEx, right? But every other piece of this could happen technically today. Now let me ask you, what of this would happen today? None of it. Absolutely none of it. Why? Well, there are about 100 different reasons, but I'll mention some of the key ones. Number one, financial relationships, reimbursement. The Major Cancer Center could not possibly come up with an agreement to share the cost of this with the Kodiak Island Critical Access Hospital, right? It just would never happen. The impetus would be to pull Dave into that center. If we just take the telehealth consultation piece, Dr. Fred would have to get a license to practice medicine in Alaska. And we can ask ourselves how likely we think Dr. Fred sitting in major city on the East Coast would be to try to go out and get a license. As easy as it is, it would be even easier if Alaska and New York were both part of the physician licensure compact, but they're not, right? So, and on and on and on. There are hundreds of different barriers to this happening. Now, if we asked ourselves, if we could do all of this, and this would be patient-centered, this would get the right care at the right time to the right patient in the right location, and this could be happening today, what would we expect to happen 10 or 15 years from now, when all of this will be even much more advanced? And shouldn't we be thinking about that, given what we've heard about the past couple of days in terms of the prevalence of cancer in our society? And again, since none of this would happen today, how do we begin to think about getting over the barriers? Or another way, as a friend of mine, Mark Fendrick at the University of Michigan puts it, why do we have Star Wars medicine on a Flintstones delivery platform? And how are we going to get off the Flintstones delivery platform? And what we said at Nehi is, let's at least advance to the Jetsons. And you can see in 1962, the animators of the Jetsons thought this is how we would be seeing doctors today on a TV screen, right, in 62. And the reason they thought that was, in the 1960s, there were already the rudiments of telemedicine. This was a system that was put in place at Logan Airport so that travelers at Logan Airport in Boston could actually have telehealth consultations with some doctors at Mass General. And it was created in the 60s, and it thrived for a few years, and then it completely died, largely for the same reasons why we don't have telemedicine today. And you can see the technology was pretty primitive even then, but it worked. It worked. It was just issues like reimbursement and defying the existing model that essentially killed it. So we at Nehi, as we started to think about all of this, we said, okay, this sounds really far out, but let's assume that the future looks a lot like the present magnified, right? Let's not pretend there are going to be lots of things out there that we can't already see. Or as the science fiction writer William Gibson put it, the future has already arrived. It's just very unevenly distributed. So let's look at the pieces of the future that exist now and think about how those might unfold in the future. Does anybody know what Figure 1 is? Okay, Figure 1 is an app that now has about going on 2 million clinicians around the world using it. And what it allows you to do is load up de-identified images of whatever sort. They can be, like this one, just a photograph. It could be a scan. It could be anything. And you can load it up into your phone and into the Figure 1 system, and you can share it with the entire community of 1 million plus clinicians who are signed up. Or you can target, I just want to send it to Mabel, Joe, and Fred, whatever. But you can essentially crowdsource medical opinion, okay? So this is being pretty widely used by residents and fellows who know about this. I learned about it because an older doctor I know said, one of my students came to me and said, what do you think of Figure 1? He said, what are you talking about? But this is today, crowdsourced healthcare. How long do we think it is before this tool comes into the widespread use by patients, right? What would stop this, right? What would be a barrier for this? So a world where patients can also crowdsource medical knowledge is not that far away, right? It's not that far away, let alone clinicians broadly being able to crowdsource knowledge. Okay. Piece of future that already exists. Piece of future that already exists, number 2, hospital at home, right? We know the hospital at home movement has been trying to pick up steam for 20 years since it was dreamed up by Bruce Luff and others at Hopkins. It is a small piece of the future that has arrived in various places. Mount Sinai in New York, for example, has a pretty aggressive hospital at home program. Almost all the evidence shows, and this, of course, hospital home is largely used for patients with acute conditions that could be treated in a hospital-like way in the home, so pneumonias and so forth. The evidence is pretty consistent, 20% savings, 99% patient satisfaction, et cetera, et cetera. That's today. And it is not in particularly widespread use. Why? For obvious reasons, right? It takes care out of the hospital. At Mount Sinai, they figured out they couldn't even send nurses who are licensed to practice hospital nursing home with the patients because they're not licensed to practice as home care nurses. So They essentially had to do a workaround and basically go to the Visiting Nurse Association and hire those nurses. So the very same nurse who sees a patient in ED cannot go home with a patient. How nuts is that? So there are all of these barriers, but we could think about this as a mode in the future when many, and we obviously already have home infusion of many cancer patients. Think about the potential for, especially as we heard, as more and more therapy becomes oral therapy, why would you not think about hospitalizing cancer patients at home to the degree they could be? Obviously, you don't necessarily think about surgery at home, but who knows what the future is going to bring. Okay, so then we look around the world and we've got major academic medical centers like Dartmouth-Hitchcock doing regionalized telehealth across, in this case, I think it's now 6 total service lines. Oncology is not one of them, but other pretty sophisticated ones are, like neurology. We could think about how far it is that how far away they might be from doing oncology consultations on a regionalized basis. Probably not far. We see the telemedicine use rising. It's still rare, of course, overall in the country, but it has risen pretty substantially in most recent years, for example, on the primary care side. And not surprisingly, the users tend to be younger people. Well, if we think about it, 20 or 30 years from now, the people who are going to be rising into the age group where cancer becomes much more prevalent will be digital natives. Are they going to put up with the system that we have today in terms of how it's delivered? Already we can see those folks are the primary users of telemedicine and telehealth. Again, cancer is different, but if we look at other disease states where these kinds of virtual consultations are becoming very useful. Ray Dorsey is a neurologist up at the University of Rochester. He sees primarily Parkinson's patients. He has not set foot in a physical clinic in 5 years because all of his patients he sees virtually throughout the state of New York. And he even has patients from Vermont and surrounding states who will drive across the border in order to have a telehealth consultation with him because, of course, licensure issue gets in the way there as well. Ray was part of a multi-site trial funded by PCORI, Patient-Centered Outcomes Research Institute, that looked at virtual care for patients with Parkinson's. Of all those diagnosed with Parkinson's who are on Medicare, about 40% never see a neurologist, never, ever, ever see a neurologist. Why? Well, you can think about the situation most neurology patients are in. They're not driving anymore. If they happen to live in a rural area and they have to get to a neurologist, that means someone is taking them there. On average, Ray told me through the study, they analyzed that to have a half-hour consultation with a neurologist means 4 hours of time by the patient. And since there's a caregiver involved, that's another 4 hours of the caregiver's time. So it's 8 collective hours to have a half-hour consultation. Needless to say, a lot of people are very receptive to an alternative. So this particular trial tested sort of standard of care, which is periodic in-person visits with a model that had a few in-person visits coupled with many more virtual visits, and you can see what the patient satisfaction numbers look like. Now, not everybody thought this was completely perfect, but significant numbers thought it was a pretty good deal. And if you just look down at the bottom, prefer virtual visits overall. So this is not they were as good. This is I preferred them. You can see almost half the participants, somewhat more than half, actually preferred the virtual visits. And if we think about the caregiver burden that was reduced, which is not captured here, but just think about this convenience piece and what that means in the lives of caregivers. And as we heard yesterday, that just the caregiver burden being as enormous, could you begin to think about peeling out of that burden the things that you could take out of it, like transportation hassles, right? Of course we could do that in this day and age. even if we can't alleviate all the rest of the burden. As we know, in the systems where the economics and the licensure issues don't get in the way, these approaches are becoming much more common. So the VA, which has a pretty major investment now in telehealth, also unevenly distributed throughout the system, as they would say emphatically, but they are thinking of as many ways as possible. They're not blocked by licensure issues within the VA. They are not blocked, and of course they have the economic incentive to use care as efficiently as possible because they are budgeted. And there you can see a lot of experimentation going on around these different modes. Pharmacy, obviously, support of pharmacists, the whole pharmaceutical apparatus, and particularly in the case of specialty pharmacy. We see models out there. This is one that was spun out of the University of Arizona, basically doing medication therapy management techniques virtually. And not surprisingly, this is particularly effective with elderly patients who have transportation issues. And they've partnered now with several other organizations, including Ohio State's College of Pharmacy, to train more and more pharmacists about how to do this virtual medication therapy management. You can imagine how useful that would be in the context of cancer. PCORI has a number of studies underway of really small pieces of this sort of virtual interventions as it relates to cancer. They're evaluating the effectiveness now of video visits versus in-person visits with palliative care providers for patients with lung cancer. They're evaluating the effectiveness of a mobile app and improving oral cancer therapy medication adherence. So there's little bits and pieces of this are emerging now that actually can be studied. Obviously, much more will have to be studied for its overall effectiveness. We've already heard a lot about the role of machine learning and deep learning and pathology and radiology. We know that is going to be a big part of the future. Again, go back to the word of democratizing. Think about the capability now to have anybody's images reviewed at the state of the art, first of all by a machine that already is doing a better job than a lot of human beings are in evaluating images, and then having those results broadly dispersed, maybe even by a patient sending up the image, crowdsourcing the image on an app, right? All of this is quite realistic. And given the plethora of technologies that are already in the marketplace, and this is today, right? So we know this is only going to get better. To pretend it's not is to say that we should all still be driving Ford Pintos, right? Things get better, thankfully, and these technologies will become much more prevalent. We heard, obviously, yesterday about a number of these technologies. Again, the future already starting to arrive in these various ways. And so thinking about a system now that has all of that present in it, what does that mean? As I said earlier, we think we can get obsessed about the technology, but it's really about technology and people. So to think about the people in the future that we will need who will be using these kinds of technologies to care for patients with cancer, including the patients themselves, because obviously they are going to have a lot more capability. They're going to be able to act a whole lot more like Dave wants to act in the future, to have a role in their cancer care. Not everyone will want to do that, but a significant number of people will, and they will not tolerate a system that does not let them do that, I do not believe. And as we think about the potential benefits, what do we know today? We would drastically increase the convenience of care. We would dramatically increase the access to care, especially in underserved areas. We would make much more effective use of our existing provider base. If we think about it, healthcare, major cost input into healthcare is labor. It's at least 50 or 60%. So what do we do in healthcare? We use that as almost as inefficiently as possible because we put constraints around it. We put licensure constraints around it. We put scope of practice constraints around it, et cetera. Cancer care is already unaffordable for the vast majority of patients. We have got to use that labor input much, much more effectively. And we've got to think about getting out of the artificial constraints that we impose on labor here. As I said, the ability to universalize and democratize knowledge is immense. We can take a lot of the friction out of the system, the lost productivity for patients. You know, Dave having to empty out his 401k to fly to the East Coast or to Houston or wherever, absenteeism from work, et cetera, including for caregivers. And it's hard for me to believe we couldn't cut the costs of care with all of that. So on top of that, if we have the system getting outside its walls more often, the evidence shows that when the system gets outside its walls, it looks around and sees how people are living in their communities and other issues that affect their care. Do they have adequate food supplies, et cetera, et cetera? Meeting patients where they are, including at home, obviously, and being an increasing factor that enables that kind of engagement. Are there any downsides to a future like this? Yes. You'd have to think very carefully about maybe not downsides, but considerations. So technologies that would assist patients with cancer in the home or their caregivers, they have to be really easy to use and really simple, particularly with compromised people. So user-centered design becomes a very important goal that we have to aim for as technologies are developed, and we had some discussion about that yesterday. Are there privacy and security concerns? Absolutely. But, you know, we just saw the new regulations drop yesterday about interoperability of electronic health records. And now we can truly see a future where people will be able to have their entire health records merged on their phones. And Apple, as you probably heard, has just announced it's doing this now for the veterans. So these things are eventually, thankfully, going to happen. There will be trade-offs around privacy and security, but we will also get the benefit of access to information. Could the future that I'm describing be enormously disruptive to existing business models and entities? Absolutely. Should it be? Absolutely. Absolutely. Why? I don't understand. I have trouble coming to grips with the notion that an academic medical center would think it was in its interest to hoard this knowledge unto itself for economic reasons and not figure out a way to address the needs of far-flung patients. To me, it's immoral that that should be the case. So would this be disruptive? Absolutely, but it's time to start thinking about how to disrupt the model for the benefit of people. As I say, there are multiple obstacles to overcome, starting with inertia, right? It's really easy to just sail along with the existing system. But I don't think we should do that. I do think we need to start doing some serious thinking about new payment models to support this type of care. Clearly, we're going to need some differently trained people in the workforce. We conceived of roles of the kinds of people, maybe it's some kind of a combination of a community health worker who also has some level of technology training to be able to go into a home and support people and make sure they know how to turn on the laptop or whatever other piece of technology has to be in their home. So that we have to think that through. I think we have to deal with some of the state laws and regulations that are getting in the way of these virtual care modalities. We actually proposed, since we don't believe the states will give up their licensure authority over health professions, we proposed creating a national parallel licensure system that people could begin to opt into, and some systems would begin to essentially accept so that perhaps over time the state apparatus would wither away as more and more people saw that the national licensure was sufficient. So again, lots of things that have to be thought through and dealt with. The recommendations that we made are lengthy. I'll just call out a few. We divided them up into 5 buckets. One was on the technology. We recommended that a public-private initiative be created to start to help health systems think through what technologies can be brought in and how. And obviously, as I said earlier, that technology developers have to put human-centered design at the center of what it is that they do. On payment, as I said earlier, we think that payers need to be sitting down with provider systems and thinking through new payment models. How would you split up the payment between the major cancer center and the critical access hospital on Providence Island? It could be done. Someone just has to do it. The regulations I've already spoken to. Again, I'll just come back to privacy and security. Why don't we have a general data privacy regulation akin to Europe's? It's unfathomable to me that we don't have that, but we don't. The other key piece is, why don't we have a plan to get to universal broadband or universal 5G technology? Botswana has a plan to get to universal broadband. Why don't we have that here in the United States, given that really this broadband will be probably, or whatever succeeds it, maybe it will be 5G, that will be a key avenue of distribution of healthcare in the future. Why aren't we making sure that that is universal? And then again, back to the workforce, lots of thinking through of new types of individuals, but also retraining the people who are in the labor force today in healthcare, because they will have to adapt to a series of very important changes that are going to play out over the next 20 years. So thinking through about how to retrain them, how to engage them even in design of new systems. Because as we heard yesterday, unless you have people who are actually in the process of delivering the care involved in the designing of these new models, there will not be buy-in to them. So how do you think through the kinds of ongoing educational and work engagement opportunities that would enable people to do that? And then lots of human factors issues, again, as I said earlier, around human-centered design. So that was our thought about what we might do to create a care workforce in cancer worthy of the name. And I'll stop there, and thank you very much for listening.